Just a few words. So I'm a KOL of INFINI. You know, INFINI is a 5-year-old company. They started during COVID. And I'm a KOL for them since 3 years. And maybe for the Middle East doctors, are you here? Do you see yourself here? It was in Dubai 2 years ago before Dubai Derma. Any doctor here? No? Yes? Who? Come. Which doctor? Please, Dr. Assam. Please. Where are you on the picture? I don't see you. Please, all the doctors, please. I want all the doctors of this picture on stage, please. Where are you, doctor? Where are you? Show me. Who? Take it. Where are you? It's you. I recognize you now. Okay. Where are you, doctor? Take it. Laser, white one. Where are you? On the right. Yes, very serious. More elegant today. Congratulations. Any more, doctor? No? So it was 2 years ago, and we did also face and butt. So today is going to be the same. And there is a surprise, because the patient of the butt is the same. So we are going to see the 2 years follow-up. Thank you so much. Spasiba and shukran. I'm also, maybe if you know me, I'm an anatomist, so we have this academy, high-class anatomy, based in Paris. Because in Paris, it's not the same, by the way, in Italy. It's very easy to have cadavers. So we have a lot of very famous, anatomists, like Bichat, who invented the big buccal fat pad, Sharpie, the lateral deep fat of the brow, and meets the SMAS. So the SMAS, I'm going to speak about the SMAS a lot. Everybody knows the SMAS? Yes? Okay. So this is the superficial musculoaponeurotic system. And this is basically all these layers made of muscle in red and fascia in, you see, white. Here, zygomaticus major, platysma, parotidoma, masseteric fascia. Here, this is the Bichat fat pad. So we are going to dive deep into the anatomy, especially the deep anatomy of the face, all right? If you want to come, we have a course in Paris in 2 weeks, in 10 days, Paris Anatomy, and also in Dubai in October. And if you are good today with your phone, if you want to make a good reel, we invite you. We invite you to Dubai. It's going to be in October. So a good reel makes you an invitation to Dubai. All right, so butt and face INFINI filler. ATP, I'm going to start with the face now. Big block, 1 hour. And then after, we go to the butts, all right? So ATP, I'm going to start by the product. I want, first of all, to speak about the product of INFINI. This way, this is known by everybody. Then I will go to the anatomy and then technique, all right? So first of all, the product. We all know from history that INFINI came first with this, cross-linked HA, XL, the strongest one, then L, M, S, and for the lips. So this is giving volume. We know that. This is not new, but I'm going to do today some live demo using that. What is more important today is the launching of V-Line. They understood that it's not only fillers, and there is also worldwide bashing of the fillers. We go more now to stimulation than volumization. So we are going to speak not only about the volumizer, like all these 5 products, also including the Aqua Booster A. And you have here, for all this cross-link HA, you have here all, the characteristic from the soft lips, S, M, L, XL, A. You have here the concentration. XL is the strongest. With 26, we go very deep, long duration. And A is the softer one. It's more superficial, and it's going to last less. So this is the cross-link HA, all right? And you have here also the plus with lidocaine. So it's interesting to see that at the beginning there were no lidocaine range. There was only, without lido. But now we have a full range. And I'm not going to detail that because we will see that this afternoon. But for every part of the face, we have a specific S, M, L, XL cross-link HA filler. But now, today, dear colleagues, ladies and gentlemen, what is quite new is the V-Line. Not the fillers making volume, but the stimulator of INFINI. And the V-Line is brand new, I think something like 1 year ago or 6 months ago. And I'm going to present you all this V-Line, actually 7. On the left, you have V5, V10, V20, V5, V10, V20. And on the right, we have V1, V2, VI, and V-body. So the number does not mean anything. It's not 5 milligram or 5 something. It's just a name, a brand. Because, for example, here this one is PLLA. This one is actually, there is no PLLA. This is, not cross-linked HA. So I'm going to detail a little bit this V line, which is brand new, all right? So we start by the V5, V10, V20. And I tell you already right now, the most important today is going to be V10, because V10 is the first PLLA product in the INFINI range. Let's start with V5. So V5, let's make it simple. It's very similar to Profilo, It's going to be used in the same way. So the composition is this one. You have here hyaluronic acid with a very specific formula, a combination of low molecular weight HA and high molecular weight HA. So it's a different, particle size. And number two, you have this molecule, which is very specific, trehalose, which is a disaccharide that is going to act on its own. So this is a V5, very specific product. I'm not going to bore you with rheology, because I personally don't like so much rheology. But basically, trehalose is a sugar, actually a combination of two glucose molecules linked together. And it's a very specific mechanism of action where you have different action, like, for example, water replacement, protein and membrane stabilization, osmotic regulation, etc., chemical stability, thermal stability. And at the end of the day, it's going to participate to the regeneration, to the stimulation of all the components of the skin. So trehalose is a very specific molecule, and with a lot of features like low hygroscopy, cryoprotection and thermoprotection, glass formation, high stability. I'm not going to detail everything, because at the end of the day, we want to see for our practice the use and the result, but it's using a very specific technology called SST. So SST stands for Selective Spectrum Technology, and is going to at the end of the day, to hydrate at the highest level the skin, all right? And the effectiveness is going to be a very long stimulation of the collagen, natural lifting also a little bit. We know that, with the 5 points, like a Profilo, is giving a little lifting, reduction also of oxidative stress, minimization of side effects. One of the characteristics of INFINI range is the safety and the purity of the product. So this is the mechanism of action of this trehalose. I'm not going to go too much into the details with this SST technology. So remember that V5 is a combo of HA, low and high, and this specific molecule trehalose. We have different protocol for V5. You see very similar than Profilo with these 5 points. It's coming in syringe of 2 ml, so every point is going to be 0.2 here in the zygoma, preauricular, angle, nasolabial, and marionette. And also interesting, we can do eventually the neck, which is brand new, and here on the midline, and here along the sternocleidomastoid. So this is the first product that I want to present you, the V5. You see different protocol. On the left, you have here not 5, but 6 points. Here, this is the protocol from before. So we can play with this syringe of 2 ml and do either, like little bolus with a needle or small lines with a short cannula. It's a very versatile product, okay? Number 2, and this is the most important for today, the V10. So the V10 has nothing to do with V5. This is not, a problem of concentration. V5, V10, no. It's just a name. And this is going to be the first range, product in the range of INFINI with PLLA. And you see here, 365 milligram. Remember that, all right? So the composition is this one. You have here 150 milligram of PLLA, but you have also 2 other components. You have CMC, carboxymethylcellulose, 90 gram, and also mannitol. And total is going to be 365 milligram. So it's coming from Korea. The manufacturer is in Korea, and it's quite consistent, robust, proper collagen stimulation. And you can read here all the effect. It's going to be the next level compared to V5. V5 is, I would say, a starting effect on collagen stimulation. This one is higher, especially by the presence of PLLA, very well known, like other molecules like calcium hydroxyapatite or polycaprolactone, to be one of the top 3 collagen stimulation. How we do that? Well, usually I do temple, cheek, neck with cannula. Usually the different entry point, but here at the sideburn, we go up to the temple, we treat all the cheek, and then we can go down. Usually we don't treat the T, the central T, forehead, nose, and lip, but why not if you want to do a full face. This is a patient who had a V10. You see here, she's a typical patient from Middle East. She's Egyptian. Some Egyptian in the yes? Salam alaikum. So she's from Dubai. Oops, sorry. And up, yes. And you see here, she has the temple, the whole cheek, and the whole neck with some entry point here at the sideburn, at the angle, and submental with a long cannula, 7 centimeter. You can do a fanning technique, and it's going to be you see here also the neck. So this is the V10, very common technique that we can use also with other PLLA or other biostimulator, right? And we don't really do the center, the T of the face. So this is V10. How we prepare, we know that with PLLA, the main problem, especially with the main one, Sculptra, is the homogenization and the accumulation of product that make, at the end of the day, some particles, some nodule. So we have, by the way, a very interesting machine helping us. It's like a centrifugate device that is going to help us to distribute, to homogenize the product. And usually, it's 10 ml for a vial. It can be 8 saline, 2 of lidocaine, yes. But if you did some anesthesia, and I will do that for the butt before, you can do just 10 saline and no lidocaine. It depends if you did or not before some specific anesthesia. All right, so this is the specificity of this product. Additional product, CMC and mannitol, not only PLLA. And number 2, this machine. Otherwise, very classic, technique. You see here a comparison of different biostimulators. So we have here V10 INFINI, but you also here another PLLA, Sculptra, polycaprolactone, Elancé, some skin booster, another PDLA, polydilactic estafil from Korea. And you see that basically we can use mainly subcutaneous, but don't forget that the main layer with fibroblast is not the dermis, it's the periosteum. And that's why I brought with me my skull, because you always need to think first the bone first. So there are some doctors, maybe you know Shino Bay from the US is a big advocate of deep stimulator, not only the dermis, but also the bone to put this PLLA. It's off-label, but I just tell you that we can use it also, because it's not just the dermis, but also the periosteum. And basically, long story short, you see here, by the way, all the molecules involved in this collagen stimulation. And long story short, this V10 has nothing, to envy to other collagen stimulators, especially Sculptra. One of the problems of Sculptra, if you have used Sculptra, is in my hand too. Number 1, the problem of distribution. It's very quickly making, some accumulation, some nodule. And number 2, in my hands at least, the lack of result. I don't know why exactly, but for example, in the butt, it's not working. And I had some, patient not happy after some Sculptra, so I stopped that. And now, quite happy since a few months with V10. Now, after V10, we go to V20, which has nothing to do with the PLLA now. We come back to hyaluronic acid. This is going to be, this time, only HA, but this time not cross-link, uncross-link, and with a 40 milligram. In V5, there were 50 milligram, plus Thealose, but this time it's 40 milligram in the syringe of 2 ml, all right? And the molecular is going to be medium weight. So I'm not going to detail again, we know all the advantages of not cross-linked HA, but basically, long story short, we can use it in 2 ways, either with a cannula below the skin or with some needle intradermal or just subdermal, papilla technique. And for example, here, we can do 6 points of injection of 0.2, a little bit like the one before, like the Profilo. You see, you do whatever you want, but I just show you that you have different way, either some bolus or some cannula threading below the skin, all right? After V5, V10, and V20, let's talk about of these four of the V line, V1, V2, VI, and V body. V body, I will use it this afternoon for the patient. The other one are for the face. So basically, V1 is the combination of fragment of HA and also some amino acid complex. So if you guys know Sunecos, it's very similar to Sunecos. So very interesting, you know, to target the skin is going to be intradermal, not subdermal. You want to target the dermis itself. And all these V1, V2, VI, V body are going to basically restoring the skin tone, the skin glow, supporting tissue regeneration, etc., etc. V2 is more or less the same. It's a vial of 5 ml, and you're going to have also fragment of HA amino acid, and this time also 2 new molecules, glutathione and vitamin C. So it's an upgraded version of V1 with, again, the main target is going to be the skin. One specific for the eye, especially, you know, the dark circle, is going to be VI. Again, same concept, fragment of HA and some amino acid complex with different composition, different molecule. But at the end of the day, same target, the skin itself, all right? And adapted to the very thin skin of the periorbital region. So I will speak after for the body, but there is also V body that we use, for example, for the butt. So this was the P. I spoke about the P, I spoke about the product, and now my favorite part, I come back to my favorite field, the anatomy. So INFINI anatomy is the anatomy we need for the INFINI portfolio, and I'm going to speak about the anatomy of the face, but anatomy also of the butt. We start by the face, and then after the butt. So face and neck anatomy. You all know the 5 layers, right? Easy. We have here the skin, the mass, the bone, and then superficial fat, deep fat, so 1, 2, 3, 4, 5. And where we can put our filler, basically, either in the deep fat, layer 4, on the right. Let me come back here. We can put our filler either in the deep fat, we don't put in the mass, in the superficial fat, and in the skin. So basically 4, 2, 1. I will always refer to 4 to 1. So 4 to 1 is a 3-layer technique that we can use for the face and also, by the way, for the body. So very important to know the anatomy of all the fat compartments. The superficial fat compartment assessed with a superficial pinch, but also the deep fat compartment assessed with the deep pinch. So for example, here on the cheekbone, this is a superficial pinch, and this is a deep pinch on the bone. So you have 2 pinch to assess these 2 layers of the fat compartments. The skin, of course, is different thickness. It's not the same, of course, here in the eyelid and in the cheek, here very thin, here very thick. So, for example, for the skin, we are going to use here VI, and here more V1 or V2, if we want to stimulate the skin itself. Then we have the superficial fat, layer 2. We have different compartments, different thickness. We need to know this. Below the superficial fat, we have the mass, which is made of muscle and fascia. We are not going to discuss so much the mass today because this is basically a no-go zone for fillers. But of course, combining with toxin is very synergistic. So all we are going to speak today about INFINI is better if you did 2 weeks before full face and neck Botox, all right? Then, layer 4, below the mass, we see all this deep fat in yellow, or this deep space here. So this is where we can put, you know, our HA crosslink XL or L, depending the area. And finally, the bone. We need to know the bone anatomy. Mainly, as I said, for crosslink filler, XL or L. But also, don't forget that maybe V10 could be, you know, interesting to inject here on the bone, for example, on the mandibula, or here on the maxilla, or here on the zygoma. You need to know also from the bone to the skin, all these ligaments. Actually, they are not ligaments. This is a misnomer. We should call them septae, because a ligament is from bone to bone. Okay? In the ankle, for example, from bone to bone. Here, it's from the bone to the skin. So it should be called septae. Like, for the cellulite, we call that septae, from the muscle to the skin. Anyway, it's a vertical structure from the bone to the skin. And we need to know the bone anatomy. I always say bone first, the bone sets the tone. For some reason, we start by the skin. So of course it's important. But I think that we should have a look to the bone first. When we do fillers, especially the cross-linked filler, there is a risk of embolization. We know that. So we need to know the anatomy of the vessels to know when a vessel is deep, when a vessel is superficial, and then when you know the vascular anatomy, you can play. If the vessel is superficial, you go deep. If the vessel is deep, you go superficial. So you can navigate knowing perfectly the anatomy. And also nerves, you need to know the nerve, not because this is a risk, but sometimes, you do a full face. And very often, I'm asked to do full face, in a workshop, and I do 10, 15 syringe. You need to do nerve block. I don't know why we are not doing nerve block in our practice. The dentists, they do 25 nerve block every day. Why we don't do it? There are many advantages to do a nerve block, and this afternoon I will do nerve block. So this is the anatomy that you are going to assess on your patient. This is the fascial vein, all the fascial artery, supraorbital, supratrochlear, etc., and also the nerve here, motor nerve, and also here, sensory nerve. And then when you place the anatomy, you are going to decide your injection. So this is what I call anatomy-based injection, all right? We come back to the 5 layers, and now let's try to connect the anatomy to the INFINI range. So, again, 4 to 1, you remember? 4 for deep filler, 3, we don't inject filler because there is a SMAS, there is a muscle, there is vessel, there is danger. This is the no-go zone, this is the red layer. We can go superficial, in the superficial fat, and we can go in the skin. So 4 to 1 for the fillers. We can also, 2 weeks before, do some toxin, and the toxin is going to target this time layer 3, because this is where are the muscle. And if for some reason you are also combining with thread, usually after the toxin, after the stimulation, after the filler, you are going to be in layer 2. So it's good to correlate your anatomy with your technique. And now let's speak especially about the fillers, about the INFINI fillers in particular. Number 1, in the title of today, it was combine treatment, combination. Now I think in 2025, it's clear for everybody, we need to combine. How we combine? For example, the first combination, you can combine a deep filler and a superficial filler. For example, here XL and here L or M. So it's a double layer filler or sandwich technique. Very interesting combination also is, for example, a deep filler, but this time not a superficial filler, but a superficial stimulator. So for example, here XL and here V10, PLLA. And I think this is one of the evolution I had myself since 2 years. I do less and less superficial filler, and I do more and more superficial stimulator. This way, we avoid the FOS, fascial overfill syndrome. Another possibility of combination is now the triple layer, 4 to 1. How we do that? We are going to do, a deep filler, as I said, and then we can do a superficial filler or even better, a superficial stimulator, and then you can treat the skin. Example, nasolabial fold. You can go with XL on the bone with a needle, then you can go superficial either with L or, for example, with V10, and then with a very small needle, 30 gauge, you can go inside the skin in an intradermal layer and to inject, for example, one of the V line, for example, V1 or V2. So you can treat really all the layers, 4 to 1, and the INFINI range allows that. So now, let's speak about the INFINI range correlated to anatomy. First of all, with the fillers, the volumizer, so XL usually is on the bone, and then you have large, medium, small, that are going to be usually in the superficial fat and more closer and closer to the skin. S can be even inside the skin, and lips is for the skin. So this is the fillers. Now, let's talk about the stimulator. What do we have in INFINI for the stimulator? We have the V line that I just spoke, V5, V10, V20, that usually is injected just below the skin with a cannula or eventually with a needle and making some subdermal papilla. And you have also V1, V2, V body. This is more in the skin. So, but it depends. You can either subdermal or intradermal. You can play, depending if you use needle or cannula. And there is also another one, but this one is a cross-linked HA, very soft, is Aqua Booster. So now, if we combine both, you have the full range of INFINI in this slide, correlated to anatomy. Here, you have the cross-link HA, all right, giving volume a lot, XL, etc., to no volume, A for the skin itself. And here you have the stimulator from the V line. So you see, it's important to know the product, but also to know the anatomy and to correlate both. Now, I'm going to review a little bit of anatomy, zone by zone. So I'm going to show you a little bit of forehead, temple, periocular, nose, cheek, perioral, neck. So 7 zones. And it's very important, like a mathematician. We doctors, we are scientists, correct? And we need to be a little bit, like a mathematician, a geometrician, to be able to know where we are and to speak the same vocabulary. Because we are from 27 countries in this room, and we don't speak the same language, but I can tell you we don't speak the same anatomy language neither. And very often, we don't understand each other just because of vocabulary. So we need to know where we are. And for example, in the forehead, let's take the forehead. When I speak about the upper lateral forehead, this is this part of the forehead between the temporal crest, between the supraorbital line, and here the medial forehead septum. So like, a mathematician, a geometrician, we divide the face in units and also in subunits. I'm sure there are dermatologists in the room dealing with skin cancer, and we need to know, for example, in the nose, we know that we need to excise the cancer in an aesthetic subunit, for example, the tip here or the lateral wall, etc. So this is the map of the skin. I'm going to start now with the forehead. So the forehead is the first zone. It's going to be now 7 videos of anatomy. And we, first of all, delimitate the forehead unit. We elevate the skin. You see very little amount of fat. I never inject superficial filler in the forehead because there is not so much fat and also for vascular risk. So you see here now the SMAS with the frontalis muscle and here the interfrontalis galea. So it's good to know for the toxin. You see it's a type 2. Frontalis are oblique, not vertical. So this is the frontal SMAS. We see here also the glabella with the procerus here and the corrugator here. The next step is going to be the elevation of the frontal SMAS. I start by the forehead because this is for me not an easy but not so complex anatomy. You have the 5 layers, while for example in the temple there is much more. So we elevate now the frontal SMAS in the supraperiosteal layer. All right? And then at this level, I'm going to go below the periosteum. By the way, if you wonder, can we inject filler below the periosteum? No, it's not possible. Your cannula cannot go below the periosteum. Always, you are going to be above the muscle, all right? You see here, why I go supraperiosteal here, because I want to show you the pedicle. Here, first of all, the supraorbital pedicle, vessel and nerve, and then the supratrochlear going through the corrugator. So you see here, supraorbital, then supratrochlear going through the corrugator. Same here. So this anatomy is not just for INFINI fillers, it's for everything, of course, for toxin, for whatever you do. We need to know anatomy. So this is here the corrugator inserted on the bone. And you have the 4 pedicles. So basically, this vessel, they are 1 centimeter above the rim. They are deep. So you don't go deep in this lower forehead, okay? But you can go deep above. I will show you. So again, let's review this section. You see a beautiful view of the frontal SMAS. Red, white, red. It's always like this, the SMAS. The SMAS is like the wine. Who loves the wine here? There are some wine, yes? I was born in Bordeaux. So when I was a kid, I didn't have milk. I had wine from my mama. So I love the wine and I love the SMAS. Red or white, but not rosé. I don't like rosé. Only red or white. You see here the SMAS, and here now the bone. Here the glabella. Be careful when you are injecting, the medial brow here. If you are injecting toxin, you might have a bleeding because we are going through the supratrochlear artery. And number 2, never inject filler here in the medial roots. I saw one time in Ukraine. Some Ukrainian here in the room? Oh! Добрый день. Как дела? Приятно познакомиться. One time in Ukraine, I think it was in Kiev, there was a professor of dermatology, I will not say the name, he injected here filler. And he was here, and I was here, I was doing anatomy, he was injecting. And he had a problem because he injected in the supratrochlear artery. I asked him, why you inject filler here? He said, because I want to raise the eyebrow. I said, why you don't do it with toxin? Because it's a filler workshop and the company is paying me. Okay, but it's not the reason. So you don't play with anatomy. Never you inject filler here because there is this vessel here, supratrochlear. You see here, supratrochlear is going through the corrugator. That's why when you put toxin here, sometimes there is a big bleeding. It's not a problem with toxin, just, little bleeding, and you make a compression, and that's it. But with filler, it can be a big problem. And this patient here, she had an embolization with livedo in the forehead. So don't play with anatomy. Always respect the anatomy. You see here the corrugator, two corrugator, and here the procerus. This is more for toxin. So you don't inject. Usually, generally speaking, I'm not afraid, but I never injected in my life filler in the glabella. I inject above, I inject in the nose, I inject everywhere in the face, but I never inject here in the glabella. And I will tell you why. There is a reason for that. Why I never, after toxin, sometimes patients, they tell you, can you do better here? Because it's not enough. Actually, I don't do it, and I will show you why and what to say to the patient. All right, so this is the glabella. And now this is the reason why I never inject glabella. I want you to understand that. Look, if I ask you what is the most dangerous artery in the face, who thinks facial artery? Facial artery, most danger, biggest danger, number one. Who thinks superficial temporal artery? Who thinks supraorbital artery? Okay. Who thinks supratrochlear artery? Me, I think yes. Look this artery. You see this artery? It's here, this one. This is supraorbital. Supraorbital is like this, is horizontal. Supratrochlear is like this, from the bone to the skin. It's very different. So remember, it's coming from the bone, from the supratrochlear foramen, and immediately you see it. It means from the bone to the skin. And it's going to be stuck to the skin. So the artery is subdermal. So if you put a needle here, you might be in an artery. And this is what happened to Marina Landau. Who knows Marina Landau? Famous and very good. During IMCAS 2017, live in front of 1,000 doctors, she was treating the glabellar lines with a blanching technique, with a filler. And it was a good technique. We were seeing the gray of the needle in the dermis. And suddenly, poof, livedo, live. And I was shocked because I said, but it's a good technique. I see the needle in the dermis. How come? And then I figure out that the artery is not really, subcutaneous. It's subdermal. So when I saw that, I said, okay, never in my life I will inject the glabella here. And if the patient has a little, remaining wrinkle, very simple. I said, you prefer me to treat that or to be blind? And they understand very well, and we don't do it. If you want to do it, you can put some thread, you can put some laser. But personally, I don't tell you not to do it, but I never injected the glabella. But I inject the radix, and I inject also here the forehead. I inject the whole face, but I don't inject the glabella because of the specificity of the supratrochlear artery. So let's play this video. This is for forehead fillers. So when a patient has a supraorbital, depression in a female, if there is, a groove here. Personally, I use INFINI L. You don't need XL because you don't need projection, and I go deep on the bone. So you see here, this is the supraorbital crease between the frontal apex and the frontal sinus. And here in between, there is this groove, which is very masculinizing. So if you want to feminize a face, or in transgender patient, it's very good to treat this groove. And usually we use INFINI L, okay? Because you don't need something sharp, projected. You just need something smooth, all right? On the bone. And remember, look, the injection is deep and horizontal. And don't forget that the vessel, they were vertical and superficial. So you are injecting below this vessel. So very often, deeper is safer. If you inject superficial here, you might have, maybe an hematoma or eventually embolization. That's why deeper is, to know the deep anatomy is very important. All right, so for the forehead, I usually use L, but eventually, if you want, this time not sub-Q, intradermal after, Botox, you can go eventually to fill some small lines with S. All right, now we go to the temple. So the temple is very, very different. It's much more rich anatomy. You know why? Because there is some additional structure. One of them is, as we know, the temporis muscle. So we have the temporis muscle, which is not present in the forehead, but in the temple and also here in the cheek with the masseter. So we are going to have not only 5 layers, but much more, 8 in the upper temple, up to 12 in the lower temple. We see here the artery, superficial temporal artery, the nerve, the frontal branch, and now we elevate the skin. Only the skin. And you see again, like in the forehead, very little amount of fat. Sometimes I inject superficially, but most of the time I inject subfacial. I will come back on that. This is the superficial temporal fascia with the artery and vein. They are actually inside this mass. Now we show you the anterior mass. Why? Because we want to show you the nerve. You know that there is a frontal branch of the fascial nerve here. And you see this branch. This branch is going to be somewhere here from the parotid. This is here the parotid, here, and boom, you see here the frontal branch in the Pitangui line, and here the zygomatic branch. And Pitangui line is from the lower tragus here to 1 finger above the eyebrow. So this is Pitangui line. You see here the nerve and here the artery. This is in layer number 4. This is in layer number 3. So this is where we inject, the subfacial technique in layer number 4. Now I show you the posterior temple. And there is this technique. I don't know if you do this technique. Who does this technique, putting a bolus here? This technique from Cotofana. You do it? You are happy? Me, I saw 2 massive hematoma and 2 massive alopecia. So this is, for me, I'm sorry to say, dangerous technique. It's not because it's published, in PRS by Cotofana that it's something for our practice. I will never do that in my practice because you have a risk with the superficial temporal artery. You can be, making a big hematoma, and I remember in Dubai 2 years ago, I saw at midnight a patient with a massive hematoma. I said, what's going on here? She told me, my doctor put me filler here to lift my jaw. Okay, good. So come with me to the operative theater. I will show you a deep plane facelift, and you will understand that injecting here has nothing to do with the jaw. It's not, scientific articles that are on cadavers that are applicable in human beings. So you see here the elevation of this mass with the artery, and now the elevation of the aponeurosis. This is not deep fascia. Everybody call it deep fascia, but it's not a fascia. It's a misnomer. It's an aponeurosis. It's like a tendon. So many bad terms in the nomenclatura anatomica. You need to change that. This is aponeurosis temporalis. This is layer number 5, like a very strong tendon, while the temporis fascia is very weak. So you see here, fascia, here aponeurosis of the muscle, layer number 5. All right? And now you see the muscle, the temporis muscle, and we elevate now the temporis muscle from the temporal fossa. And this is where, if you inject, INFINI XL for the so-called high gunshot, you are going to do it here in the angle between the crest and the rim, and you need to do it high, not low. All right? Here, this was not for fillers; it was for toxin. Sometimes we do toxin also in the temporalis for bruxism, stuff like that. So this is not for fillers, but this is to show you that when you inject either filler here or toxin here, touching the bone, we are actually intramuscular. You see? When you touch the bone, you are not on the bone, or inside the bone, you are in the muscle. All right? So this is for the temple. What we do for the temple, usually I personally do a high gunshot, one first here, and eventually one higher, but never lower. All right? So you touch the bone, and you are going to have intramuscular injection. And for the rest of the temple, I'm going to use INFINI L subfascial. How to be exactly subfascial between here the fascia and here the aponeurosis. So I'm not sub-Q. Why not? Because sub-Q, you know, you see the lumps and bumps. Also, the vein, superficial vein, are going to be dilated, so it's irregular, especially in thin skin patients. So most of the time, I go in the subfascial, between the fascia here and the aponeurosis here. I touch the bone here, and then I am below the SMAS, and then I go down, and I will be in this subfascial layer, right? So if we apply now the INFINI portfolio to the temple, what can we do? As I said, you can do a high gunshot with XL. You can also do a subfascial injection, for example, with M or L. But we can also use the PLLA. It's part, you know, of the protocol in the layer number 2. And if you want, you can also treat the skin, you know, with V1. So the temple is a good example where you can do multiple layers, not only 2, but even 3 or 4. Usually, we'd go not more than 3. But you see how we correlate the anatomy to the product. All right. So you can go here with PLLA, here with a filler, here high gunshot, and eventually, why not inside the skin with a V1 or V2. In the lower temple, as I said, we don't go on the bone. Remember that the temporal fossa is very deep here. You see here? This is very deep. So it's a big difference between the high temple and the low temple. We can go on the bone here, but we cannot go on the bone in the lower temple, all right? So we can stay, you know, sub-Q with V10, eventually subfascial with M or L, and that's it, all right? We don't go deep on the bone, remember that. And we can go inside the skin, why not, with V1. Now, let's go to the periocular area, and let's see a little bit the anatomy of this one. So here, the main feature is there is no fat. There is no superficial fat. There is no deep fat except in the eyebrow. In the eyelid, there is no fat. There is skin, muscle, bone, or septum. So you see here the skin only, and then the orbicularis oculi, and that's it. So here I show you the infraorbital nerve, which is the biggest nerve of the face. Very interesting to do sometimes infraorbital block through the oral cavity. You see big, like a small finger, big nerve. And for example, if you want to treat the tear trough, you can do the classical approach like this, or you can do also the vertical approach. This is the technique of Javier Beut from Spain. Any Spanish doctor here in the? Javier Beut, you know him. So vertical approach, actually not exactly as shown here, is going to enter here, superficial, and just at the end, boom, like a plane landing, is going to land on the bone. But it's quite interesting to think that the fold in the face, it's not always parallel injection, it can be also perpendicular injection. You know, like the Fern technique of Tom van Eyck is not going to treat the small lines here, parallel, but perpendicular. Think about it. All right, so we continue. Here we see the backs, eye backs. We can eventually, if they are too big, remove them transconjunctival. Why not? This is important to make a full assessment of the face, not just where I can put my INFINI filler, but to make a full assessment of the face. And for example, if there are too big eye bags, you don't inject fillers. Maybe you start with the surgery, you remove the eye bags, then you make fillers, but in a small quantity. All right, now we see a little bit the upper eyelid and the brow. So the difference between the brow and the eyelid, there is fat in the brow. There is deep fat and superficial fat. This is why the brow is, you know, has volume, while the eyelid is just skin, muscle, and septum. It's nothing. So here we are going to elevate the SMAS, the upper face mass, here the orbicularis oculi, innervated here by the frontal bone. You see I'm going to cut this branch. And now you see there is fat, deep fat. This is the roof. In France, we call it Sharpie fat. 1 century ago, there was an anatomist from Paris. He called that the deep fat of the lateral brow. This one here, it's called the Sharpie fat pad or roof, retroorbicularis oculi fat. So it's a good fat because as we age, it's going to lose volume, and you lose your projection, your elevation of the brow. And with our product, for example, with INFINI L or XL, depending, you can restore volume this roof. It's not such a high risk for embolization as far as you stay lateral to the supraorbital foramen. The limit is the supraorbital foramen, so you go lateral. You don't go medial. Remember, never inject the medial brow, always inject the lateral brow. So we elevate here, this is the orbicularis oculi. This is here the corrugator. This is here the frontalis. And you see here this roof, lateral to the supraorbital foramen. So here is the corrugator, and here is the roof. So you put Botox medial, and you put INFINI filler lateral, and not the contrary, if you want to avoid problem. All right? Good. So for the brow, as I said, for the brow, there is deep fat, and there is also a bit of superficial fat. So you can do, and it's very, very nice to do it, a double layer technique, deep on the bone with a needle, XL or L depending, and also superficial, so deep on the bone and then superficial with a cannula. Double layer for the brow. For the eyelid, as I said, there is no fat, no superficial fat, no deep fat. So if you want to treat, for example, the tear trough, we are going to use S on the bone, and eventually, if you want to treat the skin, you have from the V line, you have a VI, basically, all right? So we can treat deep the volume loss and superficially the skin itself. But don't put superficial filler. For example, I don't know, S. Don't put S between skin and muscle. Always put S between muscle and bone. All right. This is a good example of surgical result without surgery. You know, I'm a surgeon, so I love surgery. And if I have to, to choose, I will always, if possible, push the patient towards surgery. But patients, they don't want always surgery. Look, this patient, she had this result without surgery. She had the brow descent, the brow loss of projection, and she has also a deformity, second eyes, like me. You see, we can put the finger here. You see, like an A. What I did for her? First of all, I treat the brow with L, INFINI L, on the bone, in the forehead, on the bone, in the temple, on the bone for the brow, in the roof. Then I use M here, superficially with a cannula. So double layer technique for the brow, and you see the result. Elevation and projection. She had also Botox before, 2 weeks before, sorry. And then for the A deformity, I use S, INFINI S, with 2 entry points, superolateral and lateral, touch the bone. It's like for the subfacial. You touch the bone, and then you enter the cavity. If you touch the bone here, you are below the SMAS, and you will be below the SMAS here. Same here, touch the bone below the SMAS, and you enter. And you see here, correction of the A deformity with a full eyelid, and correction of the brow. So this, normally, this is a surgical result. But if you master, anatomy and all the layers, deep, superficial combination, you can really do wonders with this filler. We continue with now the chica, for the Ukrainian. So you see here the difference between the eyelid, there is no superficial fat, and here the cheek, there is superficial fat. You see? The fat is here, there is no fat here. And the fat you see here is not superficial. This is the souf that you see in transparency behind the orbicularis oculi. Now, is there any surgeon in the room? Surgeon, plastic surgeon. Okay, so this is a high SMAS facelift. I don't do it anymore, but it was a long time ago, this video. Now I do classical deep plane. But in this high SMAS facelift, we are going to incise the SMAS here at the superior edge of the zygomatic arch, like Timothy Martin, if you know him. And we are going to elevate here the parotidomascetic fascia. In this case, we expose the parotid, but otherwise we don't do it in surgery. And then we are going to see all the deep structure here, the zygomatic branch of the fascial nerve, here the frontal branch, so from the parotid to the masseter, all the fascial nerve branches, all right? So I make it a little bit faster. You see here, this is the subsmas, the so-called deep plane layer with pre-masseteric space here. The parotid is here. And as we reflect backwards the parotid, we see here all the branches here, frontal, zygomatic, buccal, here, mandibular. This is the fascial nerve trunk, etc., etc. All right. So this is just the starting point. You see here, this is the mid-face lift layer. Here, this is the lateral lift plane. And now I'm going to divide the superficial fat from the SMAS. We don't do that in surgery. This is just for pure anatomy. You see here the zygomaticus major. And as we divide the superficial fat from the SMAS, we are able to see a beautiful view of the SMAS. It's not easy to see that. Look, beautiful SMAS, zygomaticus major, parotidomasseteric fascia, platysma, zygomaticus minor. Here, the SMAS is much more thin, so you see the Bichat fat pad in transparent. So this is the beauty of the anatomy of the face, the SMAS, and then we are going to elevate the SMAS. This is what we do in surgery. You saw the deep plane, you pull on the SMAS, and fat and skin will come up. And now I'm going to continue medially. So I elevate the SMAS fully towards the midline, and we are going to see the beautiful now deep anatomy of the cheek. This is absolutely beautiful. Look at that. We have here, as I said, the masseter. You have here the stenon parotid duct, facial transverse artery, buccal fat, zygomaticus major. This is the SOUF, Bichat fat pad. So this is the deep anatomy of the cheek. Why I show you that? Because in the anterior mid-face, I always put my INFINI filler, especially L, deep. Here, you do whatever you want, deep, superficial, needle, cannula. But here, this is a dynamic zone because the zygomaticus major, can move your filler. If you inject superficial here, you can have, apple cheek, the filler moving up as you smile, for example. All right? So this is the cheek. As I said, in the anterior mid-face, usually I use INFINI L with a cannula, and I'm going to enter here lateral orbital line, touch the bone, and then I will treat all the fat compartments, the SOUF, medial SOUF, lateral SOUF, but there are other compartments, like for example here, there is the deep medial cheek fat, deep lateral cheek fat. So here it's a medial SOUF, here it's a lateral SOUF. So there are different compartments. I don't want to go too much into detail because it's not the purpose of today, but you need to know all these compartments. The piriform, usually I do it with INFINI XL, and I go deep on the bone. So for the anterior mid-face, deep, all right? And on the bone, it will be different compartments. There are actually 6 compartments. They are here, the piriform, but then there is deep medial cheek fat, deep lateral cheek fat, lateral SOUF, medial SOUF, tear trough. There are 6 compartments, just to let you know. And the tear trough should be the last one. Here we can inject S, INFINI S, exactly between the vein and the orbital rim. Whether you go classic or vertical, the message go high, very high. Don't stay low. Put your finger here and touch your finger. Because if you are too low, number one, you can have a lack of result, and number two, you can compress the vein. So if you don't go really at the rim here, you put your filler too low, you can compress the vein and get edema, swelling. So higher, better. Now, for the posterior mid-face, so this part, not this part, this part. What can we do? We can do everything. We can do XL on the bone, all right, for example, here. You can do also L superficial. If you have some smile lines, you can, smile lines, I mean, small lines in the skin, you can also fill them with S. And you can also use the V line. So basically, in the posterior mid-face, you can do whatever you want, and you can combine 4 to 1 layer. In the anterior mid-face, as I said, I don't go superficial. I go only deep with L. Of course, you can treat the skin. But this is the main difference between posterior mid-face, where you can do whatever you want, and anterior mid-face, where I recommend only deep. For the tear trough, only deep, but also with a different product with S. And eventually, for the skin, you can use VI, like we said before, for the upper eyelid. All right? Now, jawline. After the mid-face, let's go down for the jawline. So the jawline, you can do deep, you can go superficial, and you can do both. This is the deep jawline. I remove the platysma, so this is the deep jawline anatomy. You see here the parotid, here the masseter. The danger is here at the anterior border of the masseter with the vessel. Just to let you know, in October in Dubai, there was a blindness case in a royal family young lady, and the technique was jawline filler with a needle all the way like this. Also, here at the anterior border of the masseter. I love needle, I love bone, but if there is a danger, I don't go it. So I don't go at the anterior border of the masseter. And this patient lost one eye and was about to lose the second eye. But the ophthalmology unit of Dubai, they saved the second eye here, all right? So the technique was a needle here on the bone and embolization of the facial artery. Again, don't play with anatomy. Then where you can go on the bone, you can go on the bone 1, 2, not 3, not 4, because sometimes the facial artery is here. 5, 6, 7, yes. Prejaw, lateral chin, medial chin. So 1, 2, 5, 6, 7, you can put INFINI filler XL on the bone. And everywhere else, you can use INFINI L superficial with the cannula, all right? So for the jawline, with INFINI, you can go on the bone in the zone before with XL. With a needle, you can go superficial with L, and eventually, if you have some, small lines, you can go with S. And of course, it's part of the V10 protocol, and eventually V1. All right? Now we continue, and I'm going to speak about perioral. So perioral, different feature. The main difference between the lips and the lid is that here there is fat, and the fat is white. It's a white fibroadipose fat. You see here? The fat here is white, not yellow like in the cheek. The fat is functional, connecting the skin to the muscle. So this is a white fat. That's why we have smoker lines, or we have, like cellulite in the chin, because this white fat is retracting the skin under the action of the muscle. Here you see this is the modulus anguli oris. Here in the chin also, same. It's not really yellow, it's more white fat, all right? So this white fat is very beneficial, is benefiting of subcision. For example, when I do nasolabial, marionette, submental, labiomental, I subcise with the cannula 22 to detach a little bit, the skin from the muscle and to make some space for the filler. So you see here, this white fat strongly attached to the skin and to the muscle. And as we remove this fat, you see it's not a very clean dissection because the fat is, intricated in the muscle, in the skin. So you recognize barely here the mentalis muscle, DLI, DAO, and some white fat everywhere, all right? So what is next? I want to show you a little bit the side, especially the modulus. You see here, this is the modulus angulioris with DAO, DLI. Here is zygomaticus major. It's more for toxin. Of course, everything I'm saying today about filler, imagine that 2 weeks before I did Botox. This is a rule, Botox first to optimize your treatment. And also, treat always mentalis and DAO and platysma at the same time, because it's like a combo. Huh? You always do here glabella, forehead, crossfit, same down. Huh? Okay, mentalis, DAO, platysma, all together. 3 muscle here, 3 muscle here. All right, so for the perioral, lips and chin, what can we do? So here you see the lips, and here is the chin. What is the difference between lips and chin? What is the difference? Păjălusta. Here, dental support, here, bone support. So in the chin, you can inject on the bone. In the lips, you cannot inject on the bone, there is no bone. So basically here, you see here, there are the 5 layers: skin, superficial fat, muscle, deep fat, mucosa. You see here, the 5 layers. In the lips, we are going to stay in the anterior compartment. Why? Because the artery is posterior. All right, so this is the anterior compartment, so you can inject in this part. You don't go deep here in what we call the POOF, posterior orbicularis oris fat. You don't go here. But in the chin, yes, you can go deep in the deep dental fat and in the superficial fat, and you can combine both. So for the lips, as I said, only superficial. You can use the soft lips, but if you want a little bit, more structure, like for the Russian lips, you can also use L. Not only the soft lips from the range, but you can also use L. XL will be too much. For the chin, you can do both, deep on the bone with a needle, XL, and superficially with L. And now I want to show you one doctor. You know this doctor? He's an INFINI doctor. He's a plastic surgeon from Kenya. And he was in Dubai 2 years ago, and it was one of my patients. So I did chin filler for him during the workshop. And you see here, I did the midline, paramedian, the lateral chin to make the chin more square. I used double layer technique, deep on the bone with these 5 points to project the chin, but also 5 points lower to verticalize the chin, to make it more square, but also higher. And then with a cannula, I used 2 entry holes, and I did superficial. So it was double layer, XL and L. And this is the result of our colleague from Kenya. in the workshop. So you see a little bit of retrogenia, a little bit of double chin, no good definition. And I did only the chin. I didn't do the jawline. I did just the chin. But you see how projecting the chin improve also the double chin, the jawline, everything. So just to show, to highlight this double layer technique using XL on the bone with a needle and L superficially with a cannula. All right? And you see him on the front. Anna, you are here, Anna? Anna is here? No. All right, no problem. We continue with the neck. So the neck is the new face. You agree? As a surgeon, I can tell you, if I do a facelift, my result is going to be judged not on the face, on the neck. Beautiful neck equal successful facelift. So the neck is the new, face. Beautiful neck makes the difference. How to make a beautiful neck? We have a lot of options. Of course, surgery is one of them. But this is where V10, comes in the game, because we don't want volume here. Of course, a beautiful neck starts with a beautiful jawline, so you can treat the jawline, like we said before. You treat the chin. But if you need to treat really the neck, we don't want volume in the neck. You want, the contrary. You want definition. You want to see the muscles, sternocleido, etc. So as we don't want volume, we want stimulation. So after toxin in the platysma, 2 weeks after, you can do a full V10 neck. And we show you that. For now, just the anatomy. We elevate the superficial fat. We see now the platysma. Here is the digastric between submandibular and submental. And the message is this one. If you have double chin, it's not usually only superficial fat. It's also deep structure, like I showed you before, the digastric muscle. You see here, this is the superficial fat. And then we have the deep neck. Here, this is the digastric. Here, subplatysmal fat. And also another fat called interdigastric fat. You see here this fat between the two digastric. No way you go there blind. You go there only eventually with submental approach. This is what we call deep neck debulking. For to do whatever you want, Kibela or thread or cryoliposis, just appreciate by some maneuver the pinch test, swallowing test, platysma test, if the deep fat is also involved. And not only the deep fat, it can be also the submandibular gland. There are a lot of content here. So this is important to make a proper anatomy diagnosis and not to treat a real problem with a wrong solution, all right? If the superficial fat is not a problem, don't treat it. Just tell her, I think it's coming from the depths, maybe your gland, maybe your deep fat, and go and see Stefanelli in Dubai. No, I'm joking. Go, send her to the surgeon of your city, all right? So what can we do for the neck with INFINI? If you have some lines, for example, the horizontal lines, you can do with a blanching technique, you can do S, but in particular, this is where all the V line is going to be interesting, and especially the V10. The V10, you can do PLLA in the whole upper neck and eventually lower neck. You can also use some non-crossing HA, whether V5 or V20, sub-Q, or eventually even intradermal, in this case more V1, all right? Look, the neck, as I said, 1, 2, 3. This is the superficial fat, all right? But there is more fat. There is the subplatysmal fat, there is the interdigastric fat, there are the digastric, there are the submandibular gland, there is the myoloid muscle. So all this here is the deep neck content. So if you have, a double chin, it's not maybe this the problem, it's maybe more this. And you need, in this case, surgery. I will finish with the nose. It's 12, okay, we're good. We finish with the nose. So the nose, do we do nose filler? Who is doing nose filler? Okay. Now, who refuse to do nose filler? 50-50. Why? In my clinic in Dubai, there is a dermatologist, very good, very famous. He's not doing nose, he's not doing filler, temple, sorry. So nose filler, no, temple filler, no. So when he has a patient for full face, he's asking me to do the nose and the temple. I do it, of course I take some money, I don't do it for free, please. And, but it's interesting, the guy is super famous, he's not afraid, but nose and temple, no. He's afraid. And I think it's smart from him, because if he's not confident, let's not do it. The nose is the highest risk in the face. Why? Because there are very small amounts of tissue, and there is a lot of vessels. It's a sponge. It's a vascular sponge. So you see here, skin, very little amount of superficial fat, then the SMAS, and then we are going to elevate the SMAS like a book. You see here, I open the SMAS like a book, and then we'll see that there is almost no deep fat, a little bit, 1 millimeter. You see, a little bit of deep fat. So basically, you have the 5 layers in the nose, but you have them in 2 millimeter. It's nothing. So it's difficult to avoid the vessel, because the vessel, they are here. They are waiting for you. They are waiting for you to take your license. In Abu Dhabi, there was 2 blindness in 2023, I think, by a plastic surgeon, very famous. Maybe you know him. I will not say who. Doing surgery during injection. And 2 blindness in the same patient, in the plastic surgeon. So don't think that you are a surgeon, you will not have complication. This is exactly the contrary. And what was the cause? He used 25 gauge cannula. And a cannula is cannulating. Cannula cannulates. Cannula cannulates. So don't think cannula is not penetrating a vessel. 25 gauge, boom, inside the dorsonasal artery, blind, unilateral. One of them, royal family. You can imagine. It's in the country. All right, so what do we do in the nose? Very simple. I do, personally, just XL, very strong, like cartilage, and I go deep on the bone with a needle, with a cannula. It depends. But don't take something soft, because it can migrate. And cannula, needle depends. For example, here I use more needle. Here I use more cannula. And I hope nobody is having only, 100% cannula practice or 100% needle practice. I think you miss one, a tool. I use both. Like in a surgery, we use 10, 20 instruments. So I don't think using only cannula or only needle is good for your practice. You always use both smartly. There are some advantage for both, all right? So for example, here, for the nose, for the radix, here I use needle on the bone, but you can also use a needle like a cannula. Not like this, but like a cannula, tangential. So a cannula can be used like a needle, and a needle can be used like a cannula. You see here in the supratip, I use more here, for example, cannula. For here, the columella, I use a cannula. So if there is a hump here, you do the radix, you do supratip, and of course, you need to do also all the base, the nasal spine, the cannula, the nasal spine, the columella, sorry. And by the way, I don't do it anymore with a needle like this. I do it with a cannula from the infratip, and I do like a cartilage strut in surgery, the whole base, all right? So this is done with XL. This is the main message, and with a big cannula, 22 gauge, or with a needle. After product, after anatomy, ATP, let's talk about the technique. I'm going to show you some full face INFINI filler, and then after I will show you the patient of today. So this is a patient, very skinny, skeletonized. She had 15 ml in her face. We did everything. We did the temple, we did the brow, we did the eyelid, we did the mid-face, we did the nasolabial, preauricular, the posterior jawline. So we use the full range of INFINI using different techniques, deep, superficial, needle, cannula. You combine everything. She had also, I didn't have at this moment V10. It was 2 years ago. I used another collagen stimulator, and you don't see the results because it's just done. It's 5 minutes after. But of course, it's going to treat these accordion lines 3 months after. Another patient, very interesting. She's a female. She has a class 3 with progenia, big chin. And I did 20 ml in her face, but 16 deep. So, it's not just the number. It's not just the volume. 20, no. 20 mainly deep. It's not 20 superficial. No, don't stay just with the number. Ask which technique, etc., etc. All right? So basically, the whole face except the chin. See? Upper face, mid-face, chin, nose, lips, the whole face except the chin, because my idea was to balance the chin. It's not easy to treat a class 3 in a female because it's very masculinizing, all right? So you see her now, more feminine, more round, more rested, and the chin is the same, but is a little bit less visible. You see here, by rounding the face, we feminize her. She's more rested, and the chin is less, obvious. Especially here, you see here, she has the whole face, upper and mid face back, and now we move forward, and the chin is balancing and less visible. Another guy, another patient with mid face and lower face, double layer technique here with XL and L. Here only L. Here XL and L double layer. So here I go only deep. Here deep superficial. Here deep superficial. Another example: mid face plus lower face, 10 ml. Again, you see here how treating the chin and the jawline improve the double chin. It's not easy to do that in surgery, except maybe with chin implant, and also treating the negative vector, the whole perioral move forward, and mainly deep injection. Another one, a little bit more chubby, with mid face and lower face and also chin. You see, we move forward. Of course, we need, first of all, to lose weight and maybe to benefit from some liposuction, but at least with some filler, we improve. Interesting patient from Albania, full face. You see, she was a class 2 convex face, and now she's class 1. We did the jawline. Maybe you think the jawline is a bit more aggressive. Yes? Yes, but you need to ask the personality of the patient. Very important. For every woman, I ask them, who are you? Which type of woman are you? Are you dangerous? You want to kill the man? Or are you a soft, a woman treating men very, very well? She said, I'm dangerous. I do, Harley Davidson. So she wanted the aggressive jawline. But of course, if she's more, girl next door, down to hers, maybe a little bit softer. I'm going to ask you, who is dangerous in the room among the women? Dangerous woman? Ukrainian, very dangerous here. Who is a nice woman? Not dangerous. What is your number? I want, nice woman, not dangerous. All right, so we continue. This is very interesting patient from Peru. She's class 2. And I did deep and superficial, full mid-face and lower face. So now this is deep with mainly XL, and this is superficial, mainly with L, all right? So you see here the treatment. On one side, the anatomy and all the injection points. You see here, this is going to be deep, teardrop, medial souf, piriform, deep medial cheek fat, deep lateral cheek fat, lateral souf, jawline, double layer technique, preauricular, only superficial because you don't go deep. Here, deep and superficial. Here, superficial. And the result is this one after one side. So this side is down. This side is not down. You see all the parameters, all the vectors are up. So down, one side down, and this side not down. And at the end, this is the result. 2 weeks after, she has a bit of makeup, I know, because she has a stain here. So she wants to camouflage this one. But the most important is to see she has 20 ml in her face, 16 on the bone. And she's moving normally, she's speaking, she's smiling, she's doing everything because everything is below the muscle. If you put 20 ml of the muscle is tired. But if you put it below, no problem. So she's happy. From class 2, she come now class 1. And this is really deep reshaping with mainly XL on the bone and L. All right? This is a guy from Argentina, from some Argentina here, some Boluda. And this guy, I don't know in which region of Argentina, they have very small face. Tucumán, maybe, interior. And in the inside of the country, there is one region in Argentina, all the guys, they are like this. They have a very small, narrow face. And the guy said, I'm working, in the Argentina military army, and I want to be, more masculine. So I did a lot of filler, deep and superficial, on the jawline, and also here, superficial. So this is a male example. Another, my last patient from Peru, last week. So look, class 2, you see here, class 2, you see the nose, you see the chin, etc. And she has, I think, 20 ml in her face, 16 on the bone, with the nose, with the jawline, with the chin, with everything. Very happy. And again, it's not about the number. It's not about the volume. 20 ml, and so she's speaking very normally. This one also, 20 ml. from Mexico. This is she's a class 2, so you see here, class 2, convex, and we treat the forehead, we treat the nose, we treat the mid-face, posterior, anterior, we treat the chin, of course, the jawline. Everything has been treated, and what I want to tell you is that this is her the next day. I always ask my patients, send me a picture, video the next day when you wake up, when you are swollen after the night. I want to see the picture, and send me also a video and try to speak. If you go deep, no problem. If you go superficial, the patient is completely paralyzed. All right, so very happy. And the next day in the afternoon, she came, and again, I want you to see the dynamics, because she has 20 ml in her face from the day before, but she's not really swollen, not really bruised. She's speaking normally. She's not paralyzed by the 20 ml, because everything was done, 16 ml were done deep on the bone. So you don't alter the dynamics. This is very important to look at the facial biomechanics, not just static, but also dynamics. I'm very happy because she has class 2. And by the way, she came with the daughter, 14 years old, and the daughter is like this. Very, very big class 2. And I said, she's too young, 14 years old, so you come back in 4 years, I will treat you. Okay, now the treatment of today, this afternoon. So this is the patient that Anna found me. Thank you, Anna. Dziękuję. Grazie mille. So at first, I said, maybe not such a good candidate. But then she told me, let's do more V-line. And I think if we go now from the filler, we go to the stimulator side, I think she's a very good candidate. So we are going to do maybe some filler, maybe, some temple. I didn't see the patient so far, so we'll make the assessment together. But we can say that this is a skinny patient. We are going to treat, of course, the skin. We are going to do some stimulation of the temple, of the cheek, of the neck. So it's going to be a combination, a multi-layer technique with some filler and some stimulator, all right? So this is the end of the first part, face filler. Do you have some question? Maybe we take the microphone, Anna, because I need to drink a little bit. Any question, guys? Preguntas? Please, just take the microphone. Fabrizio, sorry. Yeah. Can you switch on this micro? Okay.
Buongiorno to everybody.
Buongiorno.
My name is Franklin Saltos from Ecuador.
Ecuador.
Yes.
Buenos días.
2 questions for you, my dear doctor. When you do the preparation of the PLA,
Yes.
Would you recommend to do it with the still water or the saline solution?
Muy buena pregunta. So this is actually a question I asked to the company, because normally it's sterile water. We know that from Sculptra, from other products like Estefil, all are recommending sterile water to have a better distribution, homogenization of the product. But, and maybe this is still an open question for the company, for Anna, and we discussed that again yesterday night. On the company side, they recommend saline. I think the question is open, and I still think that probably sterile water is helping to distribute better the product, but they have the centrifuges, the centrifugate device. So maybe, maybe they use sterile, they use the saline, which distribute less, but they have the centrifugate device, which compensate. At the end of the day, I am not sure it's making a big difference, and probably sterile water, based on what we know from Sculptra, for example, it could be recommended, yes. But
when you do the renal remodulation treatment, what parts would you recommend to go deeper and to go superficial?
I said, only deep.
Just deep.
Solamente profundo, amigo.
Correct.
Yeah, porque, why? Because it's like when you do surgery. The idea with INFINI XL is to do like we do in surgery with cartilage. When we do cartilage graft, whether it's a columellar strut here, or a dorsal strut. So you need a strong product, and it's deep. And to avoid the vessel, basically, better deep. They are everywhere, but deeper is going to be a little bit less risky. Yes.
What about the tip?
Tercera.
No. Here's the same question.
Yes.
What about
The tip.
the tip to do the projection of the tip?
Yes.
Would you go like superficial there?
Actually, there is almost nothing. I do two things for the tip. I'm going to show you the last patient that I did, by the way, 2 days ago. So I think this one, yes. So if you look at the tip here, look, very interesting. Because here I did only the tip. Why? The dorsum was okay. Dorsum was okay, okay? No problem. The angle was already open. I was just missing some projection. So what I did 2 injections with a needle. First of all, interdomal injection, like this, with a needle, boom, 1 centimeter deep, between the 2 dome. And then supradomal, on the cartilage. You understand? So the cartilage are like this. I do intradomal and then supradomal. 2 injections, one like this, one like this. In the nose, you don't have a lot of tissue, so you think that everything is superficial, but actually the idea is to be on the bone here and on the cartilage, not subdermal, if you can. Gracias. More question? Please, can you give the microphone, amigo? Gracias.
Hello, my name is Justina. I'm from UK. I just have a question because I would like to know your opinion about the technique of Dr. Arthur Swift. When he's putting a tear trough filler, he's going really, really superficial. Well, he's blending, like doing the blend 50-50 with saline first, very, very a low cross-link filler, and then he's going with really tiny cannula, really superficial, saying, because he's a plastic surgeon also, saying it's nearly the same kind of I would say facelift technique. What do you think? What is your opinion about that?
First of all, Arthur Swift is a genius. He's my friend. I know his technique. He's using Revaness Revise, and he's diluting. So yes. First of all, the dilution, I think this is very important message that I start not very long time ago, maybe since 6 months. I dilute sometimes my HA.
Yeah, it's
usually
like 50-50. And the
exactly.
Same for periorbital for
exactly.
bone.
Or temple
okay.
also. It works
yes.
very well if you want. I don't do sub-Q, but if you want to do sub-Q, you can take a filler, for example, from INFINI. It can be M or L, whatever, or even S, and you dilute 1 to 1, okay? So 1 ml of HA, 1 ml, for example, of saline. So number 1, dilution, yes. Number 2, the product, Revise from Revaness.
Yeah.
Sorry to mention that, Anna, but this is a specific product from Canada, and they make it really, really good for the tear trough. And they recommend it to do it superficially. Now I'm going to tell you my experience. When they launched that exactly 1 year ago, in Monaco 2024, Swift said, now we can go superficially in the tear trough. So what I did, I came back to Dubai, I do that. I had problems. So don't believe everything 100%.
Thank you very much, because I wasn't brave enough to do it. So that's
I did it for you. I'm older than you, so always listen a little bit the older guy. They do the mistake for you. So what I do, I go deep, always, even with this product. And then what I didn't show you, but I cannot show you everything. I do some subcision, superficial subcision with my 25 gauge. I detach the skin from the muscle. What is the advantage of that? You separate a little bit the skin from the muscle, you blend nicely the lid with the cheek, and you aggress a little bit, the dermis, you create some inflammation, and you don't inject, or maybe if you inject, a little tiny drop, not a lot, 0.05, 0.02. So the conclusion, what I do, I go deep, I subcise, and if I still have a little dent, I put a little tiny drop. But don't put everything superficially, because I had to dissolve. I say, okay, Swift is a genius. Let's listen to Swift. So at the beginning, I always trust people. But then after, I make my own experience on patient or on cadavers, by the way. I did it. I did two patients. Boom, 2 swelling, 2 Tyndall effect. I say, okay. I stop. But a little bit superficial, yes.
Okay, thank you very much.
Pleasure. Please, doctor, which country? Salam alaikum. كيفك؟ تمام شكرا.
I have a question. I have not yet worked with the V10, but from the combination, I felt in love with the combination. Regarding the PLLA, it is larger or has more amount than the Sculptra. It has carboxymethyl cellulose and it has mannitol.
Mannitol.
So my question is, from your experience point of view, did you notice that in the addition of just not having just collagen induction, we are having a prolonged duration than other
By
PLLA?
hydration, yes.
Yes, in
because
the
mannitol is
market.
hydrophilic, we know that.
Yes, that's
Yes.
what I'm saying. And the volume, regarding the volume, I have experience with the CMC, with other brands. I do have noticed that it gives me more projection than just PLLA alone. So am I saying, my question is, I do believe this product is going to be the #1 in the market regarding all other PLLAs. So is it going to give me collagen induction, projection, and stop the degradation of hyaluronic acid?
Maybe, inshallah.
Yes.
I don't know, I started January, 6 months ago, I cannot tell you.
And-
but the first feeling
Yes.
is, you have some, some volume.
That's
It
what
gives
I was
expansion.
saying.
It gives expansion. Why? Mannitol, we know that, for example, from, there are some products using mannitol, and I'm not going to mention the brand, but you know which one, from France. It gives more, you see, because there is the hydrophilic effect of mannitol. CMC, we know also the other product from Germany using,
Yes,
CMC.
yes.
Same story, it gives expansion. And PLLA, so you have 3 in 1.
Yes.
Yeah, definitely. I don't know if it's going to be #1. I hope for Anna, she will be rich. But otherwise, I think it's going
We will
to
be rich also with Anna.
So I think, yes, it's a very promising product. And since few months,
So there
Yeah.
was a volume effect. And-
expansion,
Yes.
sometimes it's a feeling. You put a product, boom, nothing happened. You put a product, boof, you have expansion, okay?
Yes.
This is the feeling I have with this one.
And what do you think is the ideal patient to inject the V10?
A skinny patient, the
Then?
patient of today,
Okay.
not, like, by the way, in Middle East, very often,
We have
patients
heavy
are a little bit
cheeks.
heavy. Yeah, this is not the perfect candidate. I think I will be a good candidate, because I have nothing of tissue. Come on stage, doctor, come.
Me?
Yes, of course, because we are different. You have a good volume, I have no volume. So I think I am a good candidate for V10, please. What's your name, doctor?
Dua Al-Amiri.
Dua, doctor, famous from Iraq.
Yes.
Superstar.
Thank you.
Assalamu alaikum.
Alaikum
So you see here, Dr. Duha, she has good, I'm not going to touch you, but you see, pinch is quite thick. So for me, she doesn't need, by the way, and she's not the best indication for V10, all right? Me, completely contrary. I have no volume. I will benefit, from V10.
Have you tried it in the hands and the neck?
Not V10,
body?
no. Usually more the face. But what is going to be very interesting is the body. Because, as a surgeon, sometimes we have, I'm going to give you an example, above the belly button, when, you have
Yes,
this
yes.
laxity of the skin and patient doesn't want surgery, it's difficult. They had pregnancy, they had a piercing, and you have this very loose skin. What do?
PLLA.
You can do PLLA, and you can combine with some machine like Morpheus. Both together, it works good.
Okay, thank you so
Nice
much.
to meet you. By the way, I have something to tell you. We'll be happy if this afternoon you help me on stage. Okay? Thank you, shukran. More questions before we go to the butt. Yes, 1, 2, 3. Take the microphone. Up. Who? Here? Where are you from, my dear?
I'm from Ukraine. I'm
Ukraine.
Dr. Alexandra from Ukraine. Is it suitable to use INFINI polylactic acid in periorbital area?
It depends. Recently, I had a patient. Maybe, if you don't, I'm going to show you this patient, okay?
Okay.
But I didn't plan it, so just give me 1 second. She had, silicone in the skin and removed very, very bad lip. So I did surgery, but I did also for her some collagen stimulation. Let me show you that if I can find the technique. So usually no, but why not if you feel that there is a big loss of collagen. So this patient, let me see if I find it. I'm going to be very honest. it was not with PLLA because it was last year and I didn't have V10. So I did it with another molecule. I think, so she had, I don't remember if I see but basically I'm going to show you the result. So the patient was like this. So it's an old patient, up. So this patient, she had, Fabrizio, maybe a little problem of connection. Can you give me the, So to answer your question, normally no. We avoid lips, we avoid nose, we avoid forehead, but after,
And
why not?
eyelids, and eyelids also is
Yeah.
not suitable. Yes.
Normally no, but if you dilute, maybe more, yes, maybe not 10, maybe 20, if you want, why not? So look, this patient, 65, very severe, dermatoporosis, and I did facelift for the cheek, the temple, the neck, but my problem was the perioral area. So in her case, so this is after the facelift, and you see that she's still not improved here. You see, the perioral area was very damaged. So she's good in the face, in the temple, in the cheek, but still big problem for me in the upper lip. So what I did for her, I did combination of stimulator and also microneedling radiofrequency, all right? So this is what I was showing here. In white is all the stimulation, and also, look, the white is also in the lip, in upper lip, lower lip, and chin. And then in red is the microneedling radiofrequency. The combination of both, I call that collagen in and out. You put collagen stimulator below, and you put a device like Morpheus or VirtuRF outside. So inside, out. So combination of both. And I'm not going to show you the whole procedure, but basically, I don't know if I think maybe, I think I put it in the perioral. Let me see here. No, it was just, this is, look, yeah, look for you, especially for you, my dear. Look here. So in this case, as I said, it was not V10. It was another one, but same concept.
Okay.
So in her case, because I wanted to try to improve these very severe smoker lines, I did, by the way, here upper lip lift. I removed the silicone by inside. So basically, there was nothing in the lip. It was no collagen, completely, damaged. And I tried to put some stimulator in this case. And I show you, and I show you if you want the result. The result, it's quite interesting because this is the result after few sessions of collagen in and out, combining stimulator and the machine. And this is, look, this is her before. This is her after only surgery. It's not enough. Surgery is not enough. I tell you, every time if I treat only with surgery, I have insufficient result. This is after 3 sessions of collagen in and out with stimulator and machine. You see her before, after surgery, after collagen, and this is the last result where I did also the nose, and look, the skin. The skin improved a lot, not just by the facelift, but because of the collagen in and out. But still, I'm not happy with the lip. I continue, okay?
Okay, thank you for your answer. And one more little
One more
question. Do you use aspiration test when you work with PLLA?
With PLLA? No.
Yes. Okay, thank you.
Why?
Thank you,
You think I should?
But sometimes cannula can come in a vessel and...
It depends the dilution. Because if you dilute by 10 or even more 20, it's very liquid, so I don't think there is a risk of embolization. However, I know that, not with this one, but with another PLLA from Korea, there was one case of embolization, but with only 2 cc dilution. So if you use a very, dense product, it can be like a filler. But here it's 10 ml, so it's like a D10, dilution 10. In the case they had in South Korea, it was a D2. They put only 2 ml. So, of course, if you don't dilute, it can be like a filler. Otherwise, for stimulator, no.
Okay, thank you.
Spasiba. One more. Doctor.
Hello from Slovenia.
Slovenia.
Yes, I have a question for V10. Do you do hyperdilution or standard one for the neck?
Neck, more, 10, up to 20. For the
20.
face, usually it's 10,
Yeah.
and for the neck, it can be 20. But it's always, very adapted to the pinch test. It's not fixed. It can be 12, 14, 16, 18. You do whatever you want. You have the protocol, but you are also independent to do whatever you want. So, depending the skin thickness, it can be everything between 10 and 20. Okay? More question? Yes, sir. Yes, doc. Which country?
Bosnia and Herzegovina.
Serbia?
Bosnia and Herzegovina.
Bosnia? Bosnia?
Yes,
Okay.
yes. So, what do you suggest to do first? Do you suggest to do first more stimulation and then surgery, or to do surgery and then after that stimulation?
I'm going to ask you a question. When you build your house, you first do the walls or you first put the paintings? Usually the foundation first. So in this patient, for example, the idea was to do first of all the surgery, because I said to me, what can I do here without surgery? I can do nothing. It's going to be, a loss of time, of money for her, of energy. So I did first of all the foundation, I did the surgery, everything I had to do, and then I did the collagen. So this is my way. But if you are not a surgeon and if you think that you can go from that to that without surgery, why not? But in this case, I did surgery first.
I don't doubt that you will make better results, but do you think if you will be maybe have a better result if you improve skin quality?
No, for surgery, no.
Surgery.
No, it's more the debate. A lot of plastic surgeons, especially from the US, they said it's not good if you do a treatment before facelift. Basically, this is bullshit. Everybody is doing treatment, and when you are 50, 55, you go and see your plastic surgeon, and we will manage. A good surgeon will always find a way. So do whatever you want, and then surgery when it's time. But it's not helping to prepare before the facelift. It's the contrary. Facelift first, and then we improve.
Thank you.
More questions, guys? Yes. Azerbaijan. Please. Yes.
Hello, this is Lamia from Egypt. I
thought it was Azerbaijan.
No, Egypt.
Sorry, but you are a twin. But she looks like you. You are like twins. Look. My goodness.
I would like to ask how much time do you usually take between the PLL and injecting fillers?
Between 2 sessions? 1 month.
Between injecting the PLL and the fillers?
Sorry.
How much time?
You can do it in the same
session?
session. We are going to do it this afternoon.
Okay.
If you go by layer, 4, 2, 1. 4 is the filler, 2 stimulator, 1 skin booster. You can do it at the same time. Why not?
Parallel. Okay.
If you are clear with anatomy, if you respect layer by layer. Let's do it. We are going to do it this afternoon.
Okay, thank you.
My pleasure. We can continue, guys? Okay, so before the lunch, in half an hour, I'm going to speak now about the buttock. All right? We go down from the face to the butt. Let's talk about the INFINI butt. What can we do with INFINI? I'm going to be very honest. You cannot do miracles. You cannot do miracles. What do we have for the butt? We have mainly surgery. And then, where is the place of the filler? In Dubai, I do both. And I can tell you, I do more surgery, of course, than fillers. Why? Because it's not easy to reshape the butt with non-surgical tools. Why? Because it's a big volume compared to the face. In the face, maximum you use 20 ml. But in the butt, you need sometimes 200, 300, 400. You need more. So less indication, in the butt. So fat, implant, fillers. This is surgery. Can I do that with a filler? No. Why? Because here I'm going to remove all the fat with liposuction, and all this fat is going to go here. So this is surgery. This is the so-called BBL, Brazilian butt lift. You do that only with surgery. You cannot do that with filler. Okay? Impossible. Now this is implant. I love butt implant because this is giving you projection. This patient, she lost a projection. You see here, she's flat. She tell me, can I do some fat? I said, no. Can I do some filler? I said, no. If you want projection, you need implant. Boom. With implant, you get what you put. No discussion, okay? 4 centimeter implant, you get 4 centimeter projection. Fat is soft. Filler is soft. It cannot push out, you know. I like to combine. I like to do liposuction here. I like to put implant here and the fat from here in the hips. So this patient, she's Turkish. Any Turkish here? No? Very pretty girl, model in Dubai. Typical Dubai girl, you know. She's investing in her body to make millions of followers and millions of dollars. So she told me, I want a very sexy butt, liposuction, fat, implant. You cannot do that with fillers. With INFINI fillers, with PLLA, with HA, no way. All right? Another one, combination. She's from Holland. And she's also very sexy. She told me, I want to be very sexy. I want to be the most sexy in Amsterdam. Okay. You cannot do that with filler. Why? Here, liposuction, implant, and fat. So why I'm showing you that? Because you need to be very honest with the patient. The patient, they don't want surgery, they don't want pain, they don't want recovery time, they don't want to pay, but they want surgical result. So you cannot do surgical result with filler, all right? This is what you can do with fillers. This is what you can do, and that's it. Halas, not more. Basta. A little bit hip dips, that's it. You need to be very honest. And I tell to my patient, I cannot do more with fillers. If you want more, it's surgery, and if you don't want surgery, it's nothing. So 10 patients coming for fillers, I'm going to say no 5 times. I said, no, I don't want to do it. Here she was good, little bit hip dips, little bit of filler. She's happy, I'm happy, everything. Eh?
How many cc?
This one, 80.
160.
Total 160. 8 syringe of 10, 8 syringe of 10 of INFINI B body. I'm going to show you that, okay? By the way, the hips are for me a better indication than the butt. Why? Because the hips, it's a hip dips usually. It's a little concavity. So you just want to feel the concavity and that's it. The butt, they always want more. It's already a convexity. So there is no limit. Here, the limit is you need just to bridge this point to this point. That's it. You don't want to make something weird. So the hip dips for me is a better indication than the butt. And also because the expansion, expandability of the hips is more here because there is no septae. Here, you see here, she has some cellulite, she has some septae, so there is less expandability in the butt, all right? Sometimes, in this very skinny patient, I combine implants and fillers. She's very tall, very skinny, no fat, no liposuction, so I put implant here and a little bit of fillers here on the side. So very sexy, probably a little bit too much, but she likes it. And for the implant, it's going to give you this projection, okay? The filler can go just a little bit for the hips. Another good example of fillers. Look, she's good before, little bit of hip dips here, and I did also the butt here, so hips and butt, and she's happy. She needs to be good before. I always classify my patient in 4. Bad, regular, good, very good. They need to be good, and we take them to very good. If they are bad or average, no indication of filler. Because I'm French and I'm Italian, I always say we cannot transform a Renault in Ferrari, okay? You need to be already Lamborghini, and you go to Ferrari, okay? If you are, Peugeot, Renault, not good. All right, so let's talk about the ATP for the butt. ATP, about anatomy, techniques, and product, all right? As usual, I'm going to, first of all, to speak about the product, because Anna will be happy. Yes, Anna? And then after the anatomy. Usually, I always start with anatomy, but today, to be nice with Anna, I change. So we have, in the INFINI range, the INFINI B body. By the way, it's manufactured here in Italy, in a company called Vida. They manufacture HA, and they give here in 10 cc syringe this INFINI B body, so for especially for butt, hips, eventually calves, for the body, right? So 10 ml. It's a 20 milligram per ml cross-linked HA, all right? Quite liquid, and I'm going to be very honest, it has some advantages and it has some inconvenience. In some area, it's advantages. For example, in the genital area, because we also use it in genital area, either penile or vulva, it's good. For example, for the vulva, you take 1 syringe of 10, you put 5. For the hands also, 5, 5. So it has some advantages. It has some inconvenience, for me at least. It's a little bit more liquid because it's 20 milligram than others. And sometimes, but it's for every body filler, it lacks projection. Okay, it's not projecting enough. So, but it's a very safe one. I never had any problem with that because there is less inflammatory reaction also. So you need to do your own experience with this one, but it's a very interesting product. And you see here, usually what I do, for one area, I try to crisscross my injection. So 2 and 3 hole, I will show you after the technique. Now, in addition to the fillers, to the B body, to this one, what is very interesting is also to use the V10 that we used for the face before. For temple, cheek, neck, we can use it also in the butt. So this is quite interesting to use PLLA, especially if we want to treat, cellulite after subcision or some skin laxity in a very superficial layer. So this is the V10 that we already saw before. I just play again the slide. It's a PLLA and also 2 components, CMC and mannitol. Total 365. All right? And there is another one, a third product that we can use in the body is from the V line, the V body. So this is, a combination of a fragment of HA plus amino acid. We saw V1, V2, VI, and there is also V body. And it's coming in a 9 ml vial. So we can you have 3 products for the body. We have the filler, we have also the stimulator, and we have the skin booster. So we can do a 3 layers treatment. And this is what we will do, by the way, this afternoon. So this is the V body, exactly like before, like V1, V2, VI, etc. Fragment of HA and amino acid, all right? With a special target, the skin. And you know that the cellulite is a skin disease. So we need to treat this by subcision, subdermal, but also by the skin itself. So look, this is what I'm going to do this afternoon for our patient. I'm going to do a 4 layers treatment. I'm going to use, so this is, by the way, this is the 5 layers. This is skin, superficial fat, superficial is fascia, deep fat, and the muscle. So of course, we don't inject anything in the muscle, but I'm going to inject B body for volume deep, then B body for the volume but superficial, then subdermal I'm going to use V10, and in the skin I'm going to use V body. So it's quite interesting, in your brain to correlate the range of the product with the layers of the face. This is my main message for today, all right? Now we go to anatomy. So let's talk about butt and hip anatomy. We have fat, we have muscle. We are going to see that. I'm going to play, first of all, a video of buttock dissection. So, it's like the nose in the face. The butt is the nose of the whole mid-body. So you need to look around. You need to look the lower back, you need to look the flanks, the waist, the hips, the thigh, etc. So this is the butt, but everything around is going to alter, at the end of the day, the butt. So there are, like in the face, some units. 6 is the gluteal unit. What is very important are the lateral gluteal unit 3, 8, 5, love handles, hip dips, saddlebacks. So these are the main ones. But you have also here the waist, here the flanks, here the lower back, sacral triangle. Here hips is the 8, 5 is the saddlebacks. So it's very important to know how to divide the zone, all right? And even when I do an injection, I think like a surgery. My patient is standing up, not laying down, and I do markings, surgical markings, all right? So they are the units of the gluteal and perigluteal zone, all right? Now we are going to elevate the skin only, just the skin, so layer number 1, and as we do so, we are going to see the superficial fat. What is the difference between the superficial fat of the face and the superficial of the butt? Septae. That's why we have cellulite. In the butt, we don't have cellulite in the face. So this is a very adherent fat, a little bit, fibrous, a little bit whitish, and estrogen dependent, developing cellulite, especially in female. All right? Septae. From the muscle, through the skin, and through this superficial fat. So you see here all these fat compartments, especially look at 3, 8, 5, very important, love handles, hip dips, saddlebacks. And it's all about to know where you are going to inject, volumize, and where you are going to remove. That's why surgery will always, be more efficient, because we have the liposuction tool, for example, for the waist, for the love handles, for the lower back. We can remove fat. With fillers, we cannot. We cannot remove. We cannot only add. Now I'm going to elevate each compartment one by one, monoblock, superficial fat and deep fat together, right? So each compartment has two fat, superficial fat and deep fat. And as I do so, look, this is the biggest one. This is the gluteal fat that we are going to inject. And as we remove all these fat compartments, we are going to see the muscle. Here is the waist. It's for liposuction usually. 3 is the love handles. This is a transition between the waist and the hips. Difficult to do. 8 is the hip dips, which is the adherence zone between the fascia, between the superficial fascia and the deep fascia. That's why we have hip dips. Hip dips is normal, by the way. And here now the saddlebacks. And as we do so, now you see all the muscle. And this muscle, they are not to inject by filler, by fat, by nothing. We don't go there, just, for example, for implants. But this is good to know what do we have below the fat, not to go inside, because we have always risk of embolism. And by the way, 2 patients died after butt filler, after embolization and pulmonary embolism. I just show you a little bit the gluteus maximus muscle, just because here we are going to see the 2 main dangers, the superior and inferior gluteal vessel. So, except if you do like this, like a torero, for the Spanish doctor, like if you do like Morante de la Puebla, you go tack like this, you cannot go, in the vessel, because you are going to be always tangential. But with long cannula, with fat grafting, yes, because they are long cannula. And that's why 600 patients died of BBL by fat embolism. But with fillers, only 2. But it's already too much. Here I show you how we put implant. The only thing you can put in a muscle is implant. That's it. Okay? This is for surgery, of course. So here again, the gluteus maximus, which is the main muscle, of course, of the area, but not the only one. Here, this is gluteus medius. Here, I'm going to show you the sciatic nerve. Again, except if you do like this, like a torero, you are not going to damage the sciatic nerve. It's very deep between the great trochanter and the ischial tuberosity. And then this is just for a surgeon, how we put butt implant inside the muscle. You see, this is the intramuscular pocket, and we put our implant in the muscle. So conclusion, never put any filler in the muscle. If you want to put something, put implant. We continue a little bit the butt anatomy with the proportion. So we know that the waist-hip ratio in a female should be between 0.6 to 0.7. This is a very feminizing feature. If you are 1, you are a male. If you are 0.7, you are a female. All right? Now I'm going to ask the men, which one you prefer? I'm sure from Middle East, they love 0.55. Yes? No? True? Which one you prefer, doctor? Yeah, for you. This one, which one? 0.6? Hey, sexy. Okay. So this is too much. This is even worse. Usually, the most ideal is 0.65, all right? It can be also 0.6, more sexy. This one is ideal. Why? Because it's close, to the golden ratio. If I ask you now which one you prefer, usually people prefer this one because it's close to the golden ratio that we know for the face, 0.618. This one is too much. It's too, too sexy. This one is a bit too square. It's too masculine. So you need to balance the waist-hip ratio. But you cannot do it with filler. You can do it only with surgery because you cannot alter the waist with filler, all right? This patient, she is one of the rare patients where I was able to measure a perfect golden waist-hip ratio just by some liposuction. She has a very tiny waist, because the ribs are inside, and she has a waist-hip ratio 0.618, all right? Another important element, where should be the hips? The hips should not be too high, neither nor too low. If they are too high, it's going to be like, we call that laterals. They do that sometimes in the US, the African patient, they have these very high hips, too high. And you don't want them to be too low. Usually, we take the cleft and we take half of the cleft and it's going to give you the hip position. Now, look, 3 patients. This one is too high, this one is too low, this one is good. This is surgery. Patients are laying down. This is what we call laterals, you see. This is too high, the projection of the hips. This is too low in the saddlebacks, and this is here perfectly. So one good point to know where to put your fillers in the hips, you take the cleft, half, and you have what I call the meridian of the butt, which is passing also here by the pubis, by the symphysis pubis. We have also some proportion from the side with between the waist and the butt, all right? So this is the waist, this is the butt. Well, as I said, patient, not all, but in Dubai, yes, they always want more. And you need to explain them that it should be this and not more, because otherwise it's going to be unbalanced. So for example, you have the waist-butt ratio between the waist here and the butt, but you have also here, very interesting, from the anterior thigh to the great trochanter and great trochanter to the butt. It should be 1618. So you need to take picture and to explain to your patient, all right? You have different shape, we know that. These are positive shape, hard and round. These are negative shape, V and square. We try to transform this shape in this one. But again, liposuction of the belt is key, and you cannot do that with filler. What is the surface anatomy of the region? You have here the cleft, you have here the sacrum with the sacral dimples corresponding to the sacroiliac joint. You have here the iliac crest, the great trochanter, the scalpelosity, the infragluteal fold, which should be short, not long. And you need to palpate the bone contour, all right? So this is the surface anatomy. What happens as we age? As we age, we lose volume, we reduce the projection, we have some skin laxity, eventually some gluteal ptosis. If you have this, for me, it's a contraindication to fillers, all right? What makes the shape of the buttocks? It's a combination of bone, muscle, fat, and skin. We cannot alter the bone. The muscle, we can alter it with workout, with some machine, like electromagnetic wave, but not with filler or fat. Fat, yes, we can alter it with fillers, with stimulator, and the skin also, especially when there is cellulite. Like in the breast, you have 4 quadrants, 1, 2, 3, 4, supero-medial lateral, infero-medial lateral, and very important is the safety line. You remember the 2 big vessels, superior and inferior gluteal vessel, they are here. They are in this zone. So, of course, if you are above the muscle, you will always be safe. But not only in depth, in position, if you are lateral to the safety line, which is 6 centimeters between the midline and this one, you will be safe. So basically, when you are treating here the hips or the lateral butt, it's very, it's almost impossible to have any problem. But when you are here in the lateral, in the medial butt, make sure you are not too deep because you could be inside a vessel. How I evaluate the butt? 3 zones. Number 1, the medial butt. Number 2, the lateral butt. Number 3, the hips. Let's say like this. Medial butt for the projection, like this. The hips from the front, and in between the 3/4. It's corresponding to the position. Hips, lateral butt, medial butt, all right? So you put the patient in front of the mirror, and you ask her, what do you want? You want this, or you want this? And depending the answer, you make your markings, okay? In this case, she wanted a little bit the hips, a little bit the lateral butt, and that's it, all right? So again, in terms of anatomy, we have to inject our filler only in the superficial fat. But we will see that there is a difference between the superficial fat and the deep fat here, but not in the muscle, because in the muscle you have all the vessel, so no way to inject any filler in the muscle. It's prohibited. By the way, it's prohibited for the fat, so it's also prohibited for the fillers. To come back to the 5 layers that we have in the butt, like, by the way, in the face, we have the same 5 layers. Skin, superficial fat. It's not really the SMAS, it's the SFS, superficial fascial system, the fascia superficialis, F, and then the deep fat, and then the muscle. So we have superficial fat, we have deep fat. And the very important slide is this one. Why? Because in the superficial fat, we have septae. We don't have that in the face. And we don't have that, by the way, in the deep fat of the butt. In the deep fat, we have some big globule, like the ibax, like the bisha, like the lipoma. You open, poop, and it's bulging out very easily. But here, no, this is creating cellulite. Why? Because you have a septate between the superficial fascia and the skin. That's why if you put too much fillers or too much fat here, not good, because you cannot expand. And you can even do the contrary. You can worsen the situation by flattening the zone. So if you put all your fillers here, not good. Usually what I do, I have a rule, 80-20. 80-20, it's a common rule every time in life. Same here, 80 deep, where you have a big lobule, it's going to expand good, and 20 here at the end of the procedure. I start deep and I finish superficial. This is a butt lift. This is to show you the difference between superficial and deep fat. So look here. You see here, this is the skin. This is here the superficial fat, compact. This is called hypodermis. When we were young, 21, epidermis, dermis, hypodermis. What is hypodermis? What is it, hypodermis? Hypodermis is the fat stuck to the dermis. So epidermis, dermis, and here is the hypodermis. But look this fat here, big lobule, like a big, big bisha, big ibax. This is the deep fat. This is completely different. This one is white, this one is yellow. So we have that also in the butt, in the hips, and usually I put more fillers in this big lobule of fat that is going to expand nicely because there is no septate, and less here in the superficial fat. We see that very well in ultrasound. I really encourage you to use ultrasound when you do butt filler because you can see here the skin, you can see here the superficial fascia, here the deep fascia, and here the muscle. So this is the deep fat, this is the superficial fat. So you need to target mainly the deep fat. Again, skin, superficial fascia, superficial fat, deep fat. 80% here, 20% here, all right? So remember that, and of course it's not fixed. It can be 70-30. We're not here to count, precisely, but to give you the message that better, deeper, and less superficial, if possible. All right? And if I want now to correlate what I said before between the face and the butt, because the idea is always to import your knowledge from the face to the butt or to the genital, I like to go deep. Because deeper, safer, deeper, more natural, deeper, less problem. What is the difference between the face and the butt? There is no nose in the butt. Yes, there is no nose in the butt. But no, there is no bone in the butt. There is bone in the face. You can go on the bone, but we don't go on the bone here. So if you want to go deep in the face, you are going to use the bony contact with your cannula, with your needle. It's easy. But in the butt, you need ultrasound. Because if you want to be exactly here, you cannot touch the bone because this is a muscle. And the muscle is a soft tissue, so you never know exactly if you are superficial, deep, or intramuscular. So if you want to target the deep fat compartment of the face or the deep fat compartment of the butt, in the face you use the bony contact, but in the butt you need ultrasound, all right? So what we are going to do for our patient this afternoon, we are going to use the INFINI range, the full range, for volume and stimulation, both. We are going to use B-body deep 80%, B-body superficial 20%. And here, when I say superficial, I don't say subdermal. Don't put your filler subdermal. Why? Because otherwise you create inflammation. It's a macromolecular long-chain HA, and if you are close to the dermis, where are all the immune system, like lymphocytes, etc., you will create inflammation. This is one of the problems we have with butt filler, inflammation. Not necrosis like for the face filler, but inflammation. So if, for example, you have a pinch of 10 millimeter here, go 5, go half distance. But what you can do, you can put V10 subdermal, because in this case, you want to target, the fibroblast, and eventually inside the skin, the V-body. So this is what we are going to do this afternoon. A little bit more anatomy. This is the maximus, this is the medius, this is the vessel. You see the projection of the vessel, 6 centimeter lateral, and again, superior and inferior gluteal vessel. They are below the muscle. So if you are tangential, no way with your 10 centimeter cannula, you go in the muscle, except in the vessel, except if you are perpendicular. But you don't want to do that, all right? Again, inferior and superior gluteal vessel below the muscle gluteus maximus, all right? By the way, here is the hip dips. The hip dips is between the grid trochanter, between the iliac crest and the grid trochanter, all right? So this is the reason of the hip dips, the bony contour, number one. Number two, there is no muscle. Number three, there is an adherence between the two fascia, superficial and deep fascia, all right? So about the fascia of the butt, you see here, this is the hip dips. So there is no muscle, and the superficial fascia is attached to the deep fascia. So this is the superficial fascia, sorry. And here also, this is just to explain you why we have fat embolism in the butt, or also filler embolism. You don't need to be only inside the vessel. If you are if you are in the muscle, because this fascia is very weak, it can be vacuum. So you don't need to be very deep, just a little bit of filler here, because it's going to be a high pressure here and a low pressure in the vein, can aspirate the Dr. Sashi, I do well no, okay, sorry. It's called indirect embolism. Don't think you need to be inside the vessel. You can be outside the vessel, but then by the difference of pressure, high pressure to low pressure, you can have fat or filler embolism, all right? This is just to show you the implant. As I said, no fillers at all in the muscle. And sometimes there are some authors, they are saying, I put my filler in the muscle. No, you put only implant. This is the only thing you can put inside the muscle, the implant. No way you put filler. You see here, skin, fat, muscle, implant, muscle, intramuscular pocket. And this is all the muscle in ultrasound, gluteus maximus, medius, minimus. So for the fillers, you need to be always above the muscle, you see, above the muscle, deep fat, superficial fat. Deep fat, superficial fat. No way you go inside the muscle, all right? Sciatic, the vessel again, and the sciatic nerve, normally no problem with our cannula. By the way, very important, I think you remember when you were 19 years old, you did some intramuscular injection. Where do we do intramuscular injection? Superolateral quadrant. And what I do for my butt filler, I start by an intramuscular injection of ceftriaxone, rocephin. Why? Because we know that with butt filler we have more problem, inflammation, sometimes infection. And why not to do it before the procedure instead of after? So you are in the perfect position to do a ceftriaxone shot here in the gluteus medius superolateral, and I will show you how I do it. This is very important to assess if there is or not ptosis. If there is ptosis, contraindication of fillers. I told you, you need to be already good to do fillers, and we upgrade you to 4, to very good. If you are regular or bad, no way. All right? You need to see if the patient has a banana roll. It's very difficult surgically, but we can do with some combination fillers, stimulator, energy-based device. We can actually not remove, but fill the fold above and below the banana roll. You need also to appreciate if there is this little drop here, very difficult to treat. Again, we can do combination of maybe a little bit of liposuction if we can, some stimulation, some device, but this is difficult situation to treat. We need to assess the bone skeleton. We have a lot of asymmetry, okay? One hip's higher than the other, some scoliosis also. So the waist is between the ribs and the iliac crest. You need to appreciate that. You need to see if the patient has a scoliosis and to explain to the patient how asymmetrical she is before, all right? So in conclusion, if you want to use fillers or fat, in the fat. And the only thing you can put in the muscle is implant and nothing more, all right? Good. Now I'm going to show you some technique. Again, what I'm going to do for this afternoon, combination of volume here, deep and superficial, and stimulation here, subdermal and intradermal, all right? This is from the company. This is what I call basic technique, but I want to show you a more advanced technique. Basically, it's fanning, okay? But fanning where? It's not, here it's showing, we don't know exactly, superficial, deep fat. I'm going to show you what I call my 2-2-2 technique. So the 2-2-2 technique, 2 entry hole with 2 cannula, 2 direction, 2 layers, okay? So this is, by the way, the patient of this afternoon, Miss Anna. 2 years back, she had fillers in the butt and fillers in the hips. So you see here, this is INFINI B-Body 10 cc syringe. And for each zone, perpendicular injection. I call that hashtag injection, to have good distribution of the product. So for example, for the butt, one here, so it's going to be, crisscross, and for the hips, the same, crisscross like this and like this, all right? 2 entry hole. And you know, like a celioscopic surgeon, he puts the entry hole and then he puts the instrument. You never remove the cannula, you just load and unload the syringe, all right? So this patient, the same, hips and butt. What I usually do, if I do both, I do the hips, the butt, and I do the transition zone. Because if you just do hips and butt, then you have a hole in between. So you always need to do a little bit here, the lateral butt, all right? Again, here, you see here, this is what I call the Eiffel Tower. You know, Eiffel Tower, 3 floors. First floor, second floor, third floor. So you are going to make a base, first floor, then you do more, second floor, and then the apex of the butt, the third floor. So it's going to be like Eiffel Tower shape, all right? Same story here, 2 angle. When I do only hips, I do the patient on the lat, decubitus lateral. When I do both, hips and butt, decubitus, prone position, maybe with a pillow below each hips. All right, so here I did only the hips. Always asymmetric. Huh? When you do hip dips, you don't do the same marking because very often it's asymmetric. I do 2 entry hole, and you need to make sure that with the length of your cannula, and by the way, I want to show you that INFINI is bringing a 10 centimeter, 14 and 17 gauge cannula, very well adapted for this procedure. If you have 7, it's too short. And 18 may be a little bit too, too small also to extrude, especially for female doctors. If you use a 18, maybe you cannot really extrude easily. Better 17, 16, up to 14, all right? Depends the patient. Sometimes tissue are resistant, sometimes no. So they have actually 2, the 14 gauge and the 17 gauge. So this is what I advised them 2 years ago, to have their own cannula, and they did it. So thank you for that. And depending the length, so here 10 centimeter, you are going to decide your entry hole. So basically, you need to use your brain before to start, all right? Because if you are too short, maybe you need to have another entry hole, and maybe you need to change the position. Maybe you have, you are going to lose your product because you did an injection, an entry hole here. So when you inject here up, the product is going out. So you need to think smartly, wisely before to do it, all right? I'm now going to show you a video. Lunch? You have to tell. 5 minutes, okay? I'm going to show you a video to show you a little bit how I do it. So very important, standing position in front of a mirror. And you need to make both sides. It's very important to have in front of the mirror, the position. You take your picture in standing up position. Then I do the intramuscular ceftriaxone shot in the gluteus medius, all right, before, not after. Why? Like in surgery. In surgery, we do the antibioprophylaxis before the incision, all right? Then this is the ceftriaxone, you see, 1 gram. And then I do the disinfection, much more disinfection, asepsia, gloves, mask, sterile draping, etc., etc. Then I do the anesthesia of the entry hole with epi, with Lido epi, and also of the zone with a cannula, all right? So this is, first of all, the anesthesia of the entry hole, then the anesthesia of the zone with adrenaline. By the way, we have adrenaline, Anna? Yes? I hope, because yesterday we didn't have adrenaline. It's very important to have Lido plus adrenaline to avoid big bruising. If they do a non-surgical technique, it's not to have a big bruising for 2 weeks, all right? So this is the injection of Lido plus epi, more or less 10 ml in 1 zone. Then we use the cannula. So the cannula here was a 14 gauge, 10 centimeter, usually between 14 to 18. Then I use, in this case, it was not INFINI. I'm going to tell you the truth. It was done for another filler, long time ago. But at the end of the day, we don't care. This is the technique that I want to show you. In this case, I used 2 different cannula. One was a 14 gauge, and the other one on the left was one for fat grafting, 15 centimeter, 14 gauge, quite interesting. All right, so look, this is what I want to show you, how we crisscross our injection, all right? The other side, same story. When you do the hips, you need to change, the position, so you need to start again from scratch. And again, the product here injected in 2 different fashion. all right, crisscross, and this is the result. In this case, 120 ml, just to round a little bit the hips, and that's it. She didn't have any problem in the butt, just the hips, all right. So this is the result. You see here the hip dips and more round hips. All right. You see here before and after. She was good before. She's a bit better after, and that's it. And you see in the different position, that's why you need to take picture in all positions, 360, because sometimes you will have a good surprise. She will tell you, oh, look, in this position with this special dress, it's good, like this. So you see in the front also hip expansion. So here, a very good case of hip dips. That's why I always give priority to the hip dips. You see here, just that, and then after, round line from the waist to the thigh. No step off here in the hip dips. I'm going to show you another example. This is from, I think, Mexico. A good patient. I always choose good patient. Good results comes from good patient selection. You will see our patient today. She's already very good. She's a fitness, she's doing a lot of fitness. She has a very good butt, and we will upgrade her a little bit. So this is what I did for her. The hips. You see here the meridian of the butt. You always need symphysis pubis here. So she's good before. She's quite skinny. And this is her after. We did a little bit of both the hips and also the butt. Look, we round the hip with these two entry holes. We also project a little bit the butt with these two entry holes. And she was good before, and she's better after. All right? So this is what we can do with fillers. And in this case, it was exactly total, I remember, 25 syringe. So it was something like 6 for each butt and 6 for each hips. Total 25. You see here, also in the front, how we round the hips. Okay. Some cases also, you see hips and butt, hips and butt, hips and butt. And the last thing I want to show you before the lunch is our patient, Miss Anna, that we are going to treat this afternoon. I'm going to show you what I did 2 years back for her already in Dubai. So she was like this before, all right? Good body. She had some liposuction, but good body. And here some hip dips. This is what I did for her. I did the butt, and I did also the hips, all right? And I did a transition zone. So this is the butt, this is the hips, and this is the lateral butt. You don't need volume. You just need a smooth transition, and you see the entry hole for the butt and the entry hole for the cannula. So this is her after. This is a little bit more round. This is not perfect, but this is better. Same for the butt. She wanted, all the girls, they want a little lift. Can we lift with filler? No, fill, it's not lifting. But if you put a little bit higher, it gives an illusion of butt, all right? But look, by the way, she's very athletic. She told me, I don't want to be, like a Colombian. She's Polish, very athletic, doing a lot of sports. So I want a little bit of hip dips. So project my butt, feel a little bit my hip, but not too much, and keep a little bit of hip dips, all right? But you see, she was good before. She's a bit better after. And also here, she's good before, of course, a little bit better after. And this is Miss Anna with our Anna, and happy patient, all right? So this is the patient. I didn't see her since 2 years. I will see, but she's happy because she wants to come back. She's coming from Poland, especially for the treatment. And I'm going to do a little bit more than 2 years back, because 2 years back I did only the volumization. Today I'm going to do the volumization and also the stimulation. So with this, I think I finish. And I want to thank you for your attention, but we are going to take maybe 1 or 2 questions before the lunch. Thank you. Gracias. Microphone. Let's take 3 questions. No more. 3 questions. 1, 2, 3. Doctor. Please.
I have a question. A lot of girls nowadays take weight-losing medications. People nowadays take weight-losing medications.
I don't understand.
The weight-losing medications like the Mounjaro and Ozempic.
Yeah, of course.
The whole muscle mass and fat mass is
altered.
decreased.
Yes.
So you prefer in these kind of patients to inject body fillers and polylactic acids, or they go directly for surgery?
It depends, case by case. But this is a problem now, yeah. What we call the Ozempic face, the Ozempic butt, with the alteration, you know, of the tissue, change the game. So basically, it depends. If she's not too bad, maybe we can try non-surgical, or if it's really too loose. What I can tell you in the butt, very often we need to go to surgery directly and to do a proper, what I call RBL, real butt lift, not the BBL. You know, you cut like this, and hop. People are afraid of this scar, but in this case of Ozempic butt, very often, you know, it's too loose. And, you know, the effects are almost permanent. Even if you stop Ozempic, studies show that the damage are very long-lasting.
So the use of the polylactic acid won't help in...
It depends if it's a little or if it's a lot. If it's just a little, why not? But usually in this patient, yes, we need to finish, Anna. We do 2 last questions and we finish. So long story short, little laxity, maybe, but usually if there is a problem of laxity, for me, it's a contraindication of filler. And you do nothing or surgery. I don't want to lose time, you know, with all this non-surgical for basically no result. All right, second question. No question? Okay, so thank you everyone. Bon appetit and see you in 45 minutes. Thank you.